Alice, would you like to start first?
I'm a legal secretary, and I was diagnosed as a schizophrenia about 30 years ago. And finally, they told me I'm a bipolar. And I think I don't need to have medication, but I help in the mental health service in these 10 years and play a role in the development of the peer support service in Hong
Kong. I am a psychiatrist in Hong Kong, and I am also trained as a psychotherapist. And actually, I have a few roles in Hong Kong. Currently, I'm leading a department of psychiatry in one of the psychiatric units in Hong Kong. I'm the department head. And I'm also actually the chair of a committee on steering mental health services in Hong Kong. And I'm also the president of the Hong Kong College of Psychiatrists. So I'm actually having a few roles. And at an international level, I'm also the secretary for education of World Psychiatric Association. So I've been doing quite a few works. Oh, briefly. Well, I actually, every day is different. But I can just give you an average share of my work every day. Well, in general, I spend like half a day on clinical work, doing direct clinical service to patients, and also doing clinical supervision for my junior doctors. And then for the other half of the day, I would spend time on doing administrative work, taking care of various departments, logistics. And then in the evening, very often I have things in the college. I have to take care of the work in the college as well, because the work in the college is basically a volunteer job in Hong Kong.
For me, I'm just a busy work at a law firm because I'm a legal secretary. But I think I can share about 10 years ago, when I was night secretary in a law firm, I have more time to do work in mental health service, like training the peer support worker, and just some research work in recovery and peer user participation and peer support in Hong Kong. So and I have some peer group in different NGOs. Also some in hospital. I have some sharing in different hospital, like in Kowloon Hospital and United Christian Hospital. So that is a very base fundamental work in Hong Kong for the past 8 to 9 years. The pilot project 9 years ago in 2011, because before that we don't have any peer support work in Hong Kong. And we have a training program to some peers, they how to write their recovery story and some helping skills. So I work with the Hong Kong University, the University of Hong Kong, and some NGO. We got the funding to start the pilot project. And after these years, we have some evidence-based research, and then now Hong Kong government since 2016, this is a paid position in Hong Kong. Basically, in all NGO, they hire peer support worker, So that means in Hong Kong, all district, we have peer support worker. I think the paid position.
I think Alice has mentioned about peer support workers being recruited by the NGO. But in fact, in the hospital authority, the public mental health system, in each clinical cluster, we have got resources to recruit 2 to 4 peer support workers in each cluster. So now, in hospital authority, we have like around 50 odd peer support workers working in the psychiatric units. Some of them work full-time, but some of them work part-time. Well, basically, because I'm an administrator in my department, so we have peer support workers being involved in various levels of work in the department. For example, we just opened a new ward in the department, and we have asked our peer support workers and some peer volunteers to get involved in design and in the utility of the new ward. And now we have several key committees in the department that have invited the peer support workers to be involved as a regular member of these committees. And besides that, we also have systematic recovery training for various health professionals. For example, we have regular bi-monthly training of doctors in recovery concepts. We invited carers and service users to come to our department to share their real life experiences of being cared by the doctors. We have also group discussions based on some of the audio taped life experiences of our service users about their encounters with the doctors. And we also have systematic training for the nurses and newcomers to the department. And we also have a Shine Recovery Center, which is basically a center where we, I would say, to support our peer volunteers. And Alice is actually heavily involved in the Shine Recovery Center of my department. So we have a crossroad there. So this is my work in the department, and then at the level of the hospital authority, because I'm involved in the steering committee on mental health. Actually, I've been heavily involved in the setup of peer support worker system in Hong Kong as well. And at an international level, in the World Psychiatric Association, we have just set up new WPA service user and carer consultancy group. And I'm very lucky to have Alice having accepted my invitation to be a member of this important consultancy group in WPA, the World Psychiatric Association. So I've been doing mostly some kind of, administrative, kind of more distal type of work in recovery care. So I'm not really someone really very frontline in terms of doing the work. In Hong Kong, we have we don't really have a mental health policy, but we have a mental health work plan. And it's been quite clear that we have stated that recovery-based care is essential for all mental health services. So this is quite clear. And because of this mandate, it has given some impetus for us to develop the peer support services in Hong Kong. And in the training of nurses, especially the community nurses as case managers, they have to undergo training in recovery as well, as part of their training curriculum. I think this has also been extended to other allied health professionals. So at the level of training, I think the newcomers, the new graduates, they have more knowledge and about recovery-based care. In terms of the current situation, I think I would think that we are still at an early stage of recovery-based care. We have peer support workers, but we don't really have a substantial number of peer support workers. And for recovery-based care, I think different psychiatric units are moving at different paces. Some places are moving faster, some places are slower. And I think the staff, especially those who have been working in the field for a long period of time, they are actually more skeptical about recovery-based care because this is not their usual way of doing things. And I think the model, as Alice has mentioned, is still very traditional. And it's still very treatment-based. So I think we still have a lot to go, I would say. Both staff and also peer support workers and even some peer volunteers and service users like Alice, they have been involved in training of staff and also in the training of peer support workers as well.
I think our situation is we are getting to develop, because before the user participation or peer support work concept in Hong Kong is no. Just in these 8 to 9 years, we developed peer support concept and peer support worker in the service. And I think we need to have more to do, to have more recovery base. And I think we need more resources to promote the recovery model in Hong Kong, because it's easy. You just give a medication to make the symptoms. But if we promote more recovery base, we need more resources to get to it. So this is difficult because in hospital or in NGO, they have the resources, it's limited resources, how they can promote more recovery. Like, but I see the hope in the service, because there are many peers, they are brave to come out, because compared before, they hide themselves. They don't want to share their recovery story. Now I know we have the human library, so they share their story. It happens many different self-organization or university. They do these human library different places. So things happen, but we need to be patient and to do more. And I always share to my peers, I'm just like a hope agent. So we just deliver the hope to the one who need. And so we all do like this to spread the hope, and there's a group people to do more empowerment work. So I see the hope in the service, but we still need time and resources to see more big things happen. We need to deliver the hope, because when I have we need to share our recovery story, and I think not only mental health problem. I think this is a life. We all have ups and downs, so we need to have the hope to see things can happen, can improve the situation. Because when I can recall when I was so sick, I don't have any motive to do anything. So I think in the message I want to share is we need to keep the hope. Hope is the key factor amongst the other factors in recovery.
How do we complete each other? I think we share a common vision here. We believe that, well, at least we believe that service users are actually the consumers of the mental health services, and they should have a say. And I think all service improvement needs to seek the view of the users, seek the view of the consumers. And actually, professional views are not antagonistic to service users' views. Actually, they are complementary. And very often, I will promote to the staff how recovery-based care can lead to win-win situation for both the service users and also for the staff. And I think in this process, I'm trying to lobby my staff, my colleagues, to buy in the concept of recovery-based care. And once they get some interest in this, once they become curious about this, then we can start some pilot projects, and then do some evaluation, do some research. And then it's here that I think Alice has a role to play, because I'm the one to sell the product, and actually Alice is the product, you see. So I'm doing the salesman work, and she's actually the product, and she's also actually the one who also produces the products, so as to say. So we're working together in a collegial and partnership way.
I thank you, Dr. always give me opportunities to participate. Like he invites me to be the board of the Research Ethics Committee. So I learned a lot from that committee. It's already 3 years now.
Well, it's an additional role for me, because I'm the chair of the Research Ethics Committee in my clinical cluster. And I think it's very important to have service users being involved in the Research Ethics Committee to give their opinion about the research.
I learn more, and I have a few articles in research. So I have the concept, and I have some ideas to do our own research in my mind. So like my peers or what you are doing now, recovery in Hong Kong. Maybe we can work it out later. So this is a great opportunity to prove even I have the mental health problem experience. This is the experience only, not ruin my own whole life. I have a role in the law firm. I'm now playing another role in the service. So this is a very good, what you say, testimony to the others. So this is what I.
And in fact, you are also assisting the Shine Recovery Center in my department as well.
It will give confidence, because people like, oh, you are mental health problem people, they will have the stigma. So what I'm doing now is I can prove I can contribute as well, and this is what the recovery. And I think if I will have some problems back, but what I learned in these 10 years, it make my life better. So I'm confident to live with the emotions inside myself. I know I sort of know more about my disease. So I know bipolar very well. So when I have some kind of manic symptoms, like I have unlimited energy, I don't want to sleep. So I will alert myself. Even I need to go back to my psychiatrist to get some sleeping pills. So I know how to live with my symptoms, or live with bipolar. So I think this experience can be shared, is a blessing. So like other, they suffer, maybe they need to learn more and know more. So give the confidence to the others is good. So even though I'm now, but I think it's a good lesson to learn. It's good experience. So even I have many when I was very sick. When I look back, it's not a bad thing, because I learned out of it from the past experience. So this is good to share. In fact, all these you think is difficulties, or just you think this is a blessing, in fact, to learn from these, and this is to make my life to go on.
Alice?
Yeah, because I get connected with the International Peer Support Association, the INAPS. I hope I can do something that to bring my peers to get connected, and we can share the experience globally. So and also I work with Dr. Roger with in that in the WPA. So I think the world is so small, so we can get connected and share the experience. And because we just only started a few years, so we need more like the how to develop the peer support worker, like the supervision, or how they handle crisis, or all these issues. Maybe we can help to set a like manual for them, or a continue education work for them. So to make them, because they have many challenges, because in the service before is professionalized. So this new role, they just started, they have many challenges, like they work with the health professional, how they work with them, and how to in the service, it's a new role that they need to have a position. So how to get there, all these. So maybe I will work with Roger for that in the future.
Right. Well, I think in Hong Kong, it's very important to do a systematic evaluation of the effectiveness and the value of peer support workers in Hong Kong. I think this is one important thing, because in Hong Kong, if we want to expand the service, if we want to get funding, it's very important to have evidence. So I think number one thing is to get the concrete evidence of how peer support workers can help the service, can lead to improvement of care of the service users. And with evidence, then we can lobby for more resources from the government to expand peer support services. I think with more peer support workers, with more involvement of service users in training, so we can actually expand the capacity of recovery trained mental health professionals. With more mental health professionals having a background in recovery-based care, the service culture, the service style, the management style at the macro and at the micro level will also change. And so I think I'm more at the level of steering these changes from the angle as a clinician, as a psychiatrist, as well as an administrator. And I think at the college level for the psychiatrist, we have currently a curriculum, training curriculum for psychiatrists, and we require the psychiatrists to have some training in recovery-based care. This is the first step. We've been discussing whether we can introduce the novel element of having service users or peer support workers being involved as examiners in professional exams of psychiatrists. So it's something quite new. And we've been discussing on that. That's going to arouse a bit of discussion, I'm sure, because we have some very senior, experienced psychiatrists who might think that is a bit too progressive, so as to say. But we are working on this direction. And the third thing is that, as Alice has mentioned, I think the world is really open to us. So there are lots of places that need to have the concept of recovery-based care being introduced to them. And that's why I've discussed with you about the possibility of having this MOOC being available to the WPA society members. So in countries like Africa, in South America, or even in Asia, they would have a chance to understand a bit about recovery care, to stimulate their interest in that. And I think among all Chinese-speaking areas in Asia, we're talking about Hong Kong, Macau, Taiwan, and China. I think Taiwan is doing some work on recovery, and Hong Kong is also now doing some work in recovery. Macau and China are not doing a lot. So I think we can form some kind of conglomerate in Greater China, so as to say in Greater China, to exchange our experience, to share what we've learned, and to promulgate recovery-based care in different parts of Greater China.